All right, so this is, I think, an exciting topic, radium-223 for metastatic prostate cancer. So objectives here, identify clinical benefits of radium-223 in these men, and then also identify sort of the current clinical trials investigating further uses of this. So there's several radionuclides we've used over the years that are sort of bone-seeking, and I won't go into the sort of boring for most people physics details of these, other than to say that most of these are what we call beta emitters, and so the distance they travel is a little bit further, which just means that they affect a little bit more of the bone marrow, and so you can have more toxicity because of that. So we generally don't use P32 anymore. Probably samarium-153 is, besides radium now, the most recent thing that most people have been using, and these have been demonstrated to help reduce symptomatic bone pain. But now radium-223 has come along. So why do we even use this? Well, if you look at this column, which I forget what that's called, family group on the periodic table, it's in the same group as calcium, which basically means that the bone or bone-forming lesions, osteoblastic lesions, see it as similar to calcium and will take that up into the bone. So it's selective specifically for osteoblastic new bone-forming lesions. So taken up there, unlike those other radionuclides, it emits an alpha particle, which basically you can just understand is a big, very big particle, and so it doesn't travel very far like the beta particles do, a very short distance, and it deposits its energy, it deposits a lot of energy over the short track that it follows, which means that it kills a lot of the cells of the short area that it goes. It's primarily excreted through GI tract. So here's just an image. This is actually, I think, from dog bones. But this is sort of normal bone, and these little lines, this is, I think, autoradiography, basically looking at the tracks of these particles. So you can see that there's not a whole lot, and sort of this is marrow and this is bone. So here's some osteoblastic bone there, and you can see that this is specifically where it gets taken up as opposed to normal bone where you don't really see much of the radium's energy sort of deposited. And again, marrow is sort of spared because these track lengths aren't very long. So the big trial and sort of, I think really how this all got FDA approved is what we call the ALSYMPCA trial. And this looked at men with castrate-resistant prostate cancer. So let me specify that up front. This is specifically for men who have been on androgen deprivation and their PSA has begun rising after that. They have at least 2 bone metastases or more. No known visceral mets. They did allow lymph node mets up to 3 cm. And then they were either had docetaxel treatment, Taxotere treatment, either were not candidates for it or they refused to get the cytotoxic chemotherapy. And they stratified by several factors and then randomized them to just best standard of care. So even though men become hormone refractory, we generally continue them on some level, and then other agents we may use are androgen blockers, so enzalutamide, abiraterone. So they either got that, which would be standard of care, or continued standard of care with radium-223. Now this is given as a once monthly injection for 6 months, and then they were followed after that. So I would just point out, so all patients got whatever the standard of care was. So they didn't get docetaxel along with it, but they could get pretty much any other therapy. So in looking at this, one of the primary outcomes, or main outcomes here, was actually overall survival, and there was a significant benefit of about 3 months in these patients. And then when you look and break down sort of by groups, pretty much most groups benefited. Importantly, I point out, so previous docetaxel, so whether they had had prior cytotoxic chemotherapy or not, they still benefited and had an overall survival benefit from this treatment. One thing that we look at, and one of the things I'll show you, is symptomatic skeletal events and pain relief. So whether patients were taking opioids at the time or not, they still got benefit here. So again, one of the main things they were looking at were skeletal events, which they defined as having to get external beam radiation, so for palliation of pain, surgery, core compression, or a pathologic fracture. And so overall, it doesn't reduce the total incidence, but it does delay the time to having a skeletal incident. And then in looking at the adverse events, really when you break this down, they're very similar. So when we look at grade 3 plus acute toxicity, The main one that's different is there's more thrombocytopenia with radium-223, so 6.5% versus 2% placebo. And really, even though I'll tell patients about a risk for diarrhea, nausea, vomiting, some GI toxicity, it really wasn't significantly different here in terms of really high-grade toxicity for these patients. So they've done subsequent analyses of this trial, sort of secondary analyses. They found that there was a reduction in the length of hospital stays with the patients who got treated with radium-223. And then they also looked at patient-reported quality of life outcomes, which is what a lot of our trials are doing now, because even though sometimes the doctor feels that there's a difference in something, what the patient actually senses, their subjective response to treatment, is sort of most important. So as you can see early on, for the patients who got radium-223 treatment, their patient-recorded quality of life decline was significantly less than those who did not. And these are sort of two different types of surveys. So one thing here is the effect of radium is really on the bone. So even though that's where the osteoblastic prostate cancer is, and we will see, they do see a drop in PSA with this treatment, the correlation is actually not as significant as with the alkaline phosphatase. So the thought is that the effect of the radium is primarily on the tumor microenvironment in the bone, and so that's why we see the biggest change really in the alkaline phosphatase. So that's sort of one of the best ways, it seems, to monitor whether the treatment has been effective. And so here you can see where the mean baseline decreases significantly in the patients who got the radium-223 versus those who get placebo, it just continues to rise. And then when you break down the survival of patients who got radium-223 and either had a response or did not have a response in their alkaline phosphatase, survival was significantly better in those patients who did get a response, so decline. So some of the ongoing and future trials involving this, even though sort of concurrent use of abiraterone and enzalutamide were allowed on the trial, it wasn't specifically like planned. And so now some of the trials are looking at actually randomizing patients to that one treatment plus or minus radium-223. Most of these, I'll point out, are in metastatic castrate-resistant prostate cancer. There is a trial for newly diagnosed metastatic prostate cancer with at least 2 or greater bone mets combining androgen deprivation plus or minus radium-223. So we are sort of moving that up sooner in our algorithm for when we offer these patients this treatment. So the questions for the pre-test, post-test. Which of the following unsealed sources, so that's the radionuclides, has demonstrated overall survival benefit in men with bone mets from prostate cancer? And it's radium-223. And then what patient population is this currently indicated? So men with low-risk prostate cancer, no. Men with biochemical failure after prostatectomy, no. Men with visceral mets, no. But men with castrate-resistant prostate cancer metastatic to bone. And the reason for no visceral mets is because this is selectively uptaken in the bones. So in summary, radium-223 is indicated for use in men with castrate-resistant metastatic prostate cancer to bone. When it's given with the standard of care, it improves overall survival and increases time to skeletal events in these patients. It can be given either before or after cytotoxic chemotherapy, and ongoing trials are investigating the benefit of this with other systemic agents in earlier and castrate-sensitive disease. All right, well, thank you everyone for coming.